Morning, everybody. I know you guys are all on mute, but thank you for being here. It's so nice to see you, even if we can't see each other in person. So great. Why don't we go ahead and get started? And I'm going to throw immediately the ball to Bob Kaiser.
That sounds great. Thanks, Christine. Hi, my name is Bob Kaiser. I am the Associate Director of SAIL, and we are so excited to, as Christine said, see you, even virtually, during these tough times. And we're really excited for our first webinar in our series, Navigating Uncharted Waters, Simulation in the Age of COVID-19. So this is our first of five webinars, and as I said, we're really excited that you're here.
All right, great. So for those of you who don't know me, let me introduce myself. My name is Christine Park, and I am the Director of Simulation and Integrative Learning Institute here at the University of Illinois College of Medicine. I also am I have a clinical role, and that is as an anesthesiologist. I've been at UIC for about 2.5 years. And we are, so the SAIL, the Simulation and Integrative Learning Institute, is part of the Department of Medical Education, which is in turn a part of the College of Medicine. And we also exist as a part of a larger collaborative with the College of Nursing, College of Pharmacy, as well as our other campuses, medical school campuses. So we need to start with some disclosures here. Between Bob and we have a number of assistants. And those assistants may be making their presence known at some point, whether visually or audibly. And so just in case they show up, at least you will know who they are. Great, so why are we here today? Well, it's really about coming together as a community of practice. And I think one of the issues and one of the challenges that have happened during this pandemic is that everyone has had to immediately narrow down to basically a very narrow horizon. So what's right in front of my face? And I think because of that, in many ways, our larger communities of practice may have broken down into many more isolated individual communities of practice. And we really wanted this to be a place for exploration and a place for sharing on the topic today, which is about dealing with policy challenges to sim centers. We want to propose that we use a set of agreements as a group here that are basically the simulation agreements that we use at UIC. And they're things like make room for and find worth in all voices, be respectful of time, including speaking time. This is actually our first voyage into doing something like this. So we're going to ask you to please own this with us and try it on. And there may be some glitches, we hope not. Really to say what we feel. And maybe one that doesn't really apply very much is the suspend disbelief, but maybe somehow that applies as well. So thank you for agreeing to these with us. So to sort of set the context here, we had in the world on February 1st, 2020, less than 15,000 cases worldwide. And as of today, we have about 2.2 million cases around the world. And one of the things that we noticed is as the pandemic worsened and as people were bracing for surges, we noticed that there was a great deal more variety and a great deal more creativity around people's thinking, practices, solutions, and so forth. And that's not only in simulation land, but really throughout the clinical enterprise. And we found ourselves wondering, what is everybody else doing? How is everybody else adapting? So that's why we decided to launch this series. So here's what we're going to talk about today. I'm going to talk about 3 main subject areas. The first is in using simulation equipment for real patient care. The second area is using simulation spaces for real patient care. And then the last area is about simulation staff safety. Should our staff, our non-clinical staff, be considered essential or not? So we made a choice to use the Zoom meeting format rather than the webinar format because we wanted to hear from you. So we're going to invite people to participate in 2 different ways so that you'll see that there's some polls. And then like a radio talk show, we want to have your live on-air comments. And so we'll be giving you some instructions on how to do that. So how to make your voice heard, literally today. So for the trigger questions that we will propose, you can indicate if you want to make a comment in the chat box, send a chat message to Bob that says favor, if you are in favor of the topic being discussed. If you're against, type against, or if you're conflicted or unsure and you want to make a comment to that, type the conflicted. We'll invite you to contribute as time allows. And then how you'll know is the host will unmute, Bob will unmute you and then call on you by name. Okay, great. Bob.
Yeah, so topic 1, what was interesting when this entire thing began? At our center, we got an interesting request. We had a request for use of equipment that we usually use in our simulations for hospital use, for real patient care. And it kind of threw us. We were a little taken back by it. And so we have our first poll question because we want to kind of see where you guys were at with this. So first poll question. What is your general reaction to the concept of providing simulation education equipment for real patient use during this pandemic? So there's I'm in favor, I'm against it, or I'm conflicted. So again, what is your general reaction to the concept of providing simulation education equipment for real patient use during this pandemic? And there's so many things to consider when thinking about loaning out the equipment we use in simulations. So. And we're great. So we'll give just a couple more seconds. And thank you for the responses. Great. So we're going to end it right. No, they're still coming in. They're still coming in. Good. Okay.
Wow. So fully 50% of people are in favor, only about 7% against, and then another about 50% of people conflicted. So we are going to share with you what we faced.
Mm-hmm.
And Bob, I can't do the stop sharing. Okay, great. So the request that we got was from a group of faculty who got the idea, a very good idea, that if they could use our point of care ultrasound handheld machines, they could reduce the amount of disinfection that had to happen between uses. And they also thought it might even be possible to let an individual device stay with the patient throughout their entire hospital stay and not have to go back and forth between different patients. And so while we felt that the idea was great, here are some of the things that we've discovered or we felt were challenges. So first of all, in our system, the hospital system and the College of Medicine are in 2 entirely separate buckets, budget-wise and reporting structure-wise. And so we felt that there were some significant challenges in terms of how to account for that difference and who would take liability, who would take responsibility, and so forth. If a piece of equipment got damaged or very likely went missing, who would be responsible for that? The other thing is that the equipment we have isn't kept up by our clinical engineers for actual patient use. So our equipment is new, so we have a high likelihood of it working correctly. However, we can't guarantee that. And we also don't have warranties. And in fact, the agreement that we signed with the company to get the cheaper price was that we were going to only use it for education. So we did feel conflicted about this. Ultimately, what ended up happening is I engaged our College of Medicine dean, who engaged his counterpart in the hospital, the CEO, and they had a discussion that if the hospital felt that they needed to execute that priority, that the hospital would take ownership of the equipment at that point, and either reimburse us later with the machines or for the cost, that piece to be determined down the road. So that's the agreement that's in place now. We haven't heard the word that the hospital intends to pull the trigger on that decision yet. So that is what our experience was. We'd now love to hear about other people's thoughts. So here we go. Should SIM equipment be used for real patient care during the pandemic? So if you'd like to share a comment, type in the chat box favor, against, or conflicted.
Great. Actually, Christine, we actually have some people who are wanting to comment. So Daniel Brown, I'm going to unmute you, and you are on the air.
Yeah, you had some extenuating circumstances with the agreements with the equipment that have moved me to conflicted.
Okay.
But we've shared some of our exam beds and things that are I think a little bit less of a for a little triage center that they wanted to put together. So at that level, I'm totally in favor. But when it comes to equipment that you have different standards for on educational versus patient use, yeah, that brings up some interesting issues.
That makes sense. Thanks. Okay, one more in favor. So, well, I guess that was a conflicted. So, James Reed, you are on the air.
Hi, everybody. My name is James Reed. I'm the Associate Director for the Clinical Skills Center at the Ohio State University's Wexner Medical Center and College of Medicine. I just wanted to say, so we have provided a number of different things, from PPE to hospital beds to 4 ventilators for the Med Center to have access to during this pandemic. We're very much in favor of doing this, as it helps to facilitate our response. And I think it's a little bit different than some of the things that you all were talking about, because we are jointly within both orgs. So our funding model, our reporting structure includes not only the College of Medicine, but also the medical center. And so a lot of our equipment is actually maintained by the medical center's clinical engineering department. So when we kind of entered into this, we didn't have that same sort of uncertainty about who's financing this, who's maintaining these things, who's preparing them, so to speak, to go into the clinical setting. Instead, our main concern is now thinking about it from the perspective of, on the back end, what are we going to need to do with this equipment to ensure that as it comes back to us, as it goes back into educational use, it's been properly cleaned, it's in an appropriate state for us to then utilize it for the needs of our constituents.
Yeah.
I actually have a follow-up question to that, which is, what have you put in place to ensure those things? Or is that still to be determined?
It's going to be determined as we go in a lot of cases. So, for example, our hospital beds are with the bed shop right now. They are not currently, or the last time I checked, they weren't currently in use in the hospital setting yet. So they've been checked over, they're good to go, they're ready if the hospital needs them. If they never move from the bed shop into the clinical setting, then we won't really need to address what are we going to do to, repatriate these back into the SIM center, so to speak. But if they do end up in that clinical setting, then we'll have to have some conversations about, well, they'll need to be replaced, or they'll need to go through a proper cleaning protocol. And we don't have those details totally ironed out at this point in time.
Yeah, that makes sense.
Great, thanks.
Thanks, James. Great. So we have someone who is against the idea. Grace Gephardt, you are on the air.
Hey, I actually will say that I think I end up being conflicted as well, even though I initially was against. I mean, that's a snap judgment for me. We did have the conversation here at our center, and actually we did give the little amount of PPE that we had over to be available for clinic or in-hospital use. However, we came to the decision about most of our equipment is hand-me-down equipment and hasn't been handled by clinical engineering for a long time. Some of it in actuality is not even the equipment that's being used in our hospital at this point. And so for that particular kind of equipment, it was just a hard stop. It seemed like a safety issue for many reasons.
That makes sense. Great. We're going to take one more conflicted, actually. It sounds like that's what we've had from Robin Wagner. Let me mute you. I have to go through Okay, you're on the air.
Hi, everybody. Sorry, there's that other world life going on around me. So excuse that ringing in the background. I was conflicted because I am in a College of Nursing simulation lab specific. And I had much of the same concerns about our equipment. We do not keep it up to date with any biomedical engineering or anything like that. We were asked by the hospital in specific for thermometers, not anything else but thermometers. And so we were looking at how do we keep enough equipment for ourselves so that when we're able to resume, that we have that, as well as how do we check that? So what we turned out is our dean had us look at what we needed to resume, what we could safely give to them, but with the caveat that they had to have their biomedical engineering people look at it because it had just been so long since it was calibrated in any fashion. And then we just said, there you go, you're welcome. We really don't want them back. Which handles it's a thermometer. It's not like a big expensive piece of equipment. So that was an easy one. But that way we avoided, do we clean it? How was it cleaned? How was it handled while it was there? And it's safe to come back into the academic world.
Makes sense.
All right.
Great.
Great. Thanks, everybody, for the comments. Somebody just private messaged me here that they ended up making an extensive list of items and made a plan for, similar to us at UIC, a transfer of ownership to the School of Medicine, from the School of Medicine to the hospital if necessary. Great.
Great. And
so moving on. Oh, wait, go
and I
ahead.
had a private message that actually leads us into this one. It's interesting.
Perfect.
About how centers as a whole. So the idea of, okay, we had the request for equipment. Okay, that was an interesting discussion amongst us. But then came the opportunity for us to consider our space for actually surge clinical, real patient care space. So our second poll question is this. So has your simulation space been considered for potential surge capacity for real patient care? So yes, it has been used and adapted. Yes, but it hasn't been needed yet. Or no, it has not been requested. So again, has your simulation space been considered for potential surge capacity for real patient care? So we have a lot of answers coming in pretty quickly. That's great. I want to hear from the one that said yes.
Wherever you are, make sure we hear from you.
Yeah, put it in the chat. That is you. I want to hear from you. So, yeah. Great. So I'm going to go ahead and end this poll and show the results. Here are the results. So we have.
So great. So it looks like predominant 70% of people said it hasn't been, 30% yes, but hasn't been needed yet. And one person that we're going to be really keen to hear from says that it actually has been used and adapted. Great. Can you make that poll go away? I can't make it go away. All right. So to share with you the situation that we were in at UIC, we were asked whether the hospital might use our simulation center for surge capacity. The things that we thought were really interesting and challenging to consider were largely around safety. So one area of our center is set up largely as outpatient clinic rooms. That seemed like that would be easier to adapt. But there's another area of our center that are set up as acute care areas, so inpatients, ICUs, or emergency rooms. And we felt that there would be some significant safety issues if that space were potentially to be used for clinical care like an inpatient setting, For example, our wall oxygen in most of the rooms is not real oxygen, but it reads visually exactly like real oxygen. The monitors, for example, are TV monitors. They're not actual vital signs monitors. And yet at the same time, there are certain things that are real. The defibrillator is real and it's live. So it potentially could be used if you needed to. So fortunately for us, our space was put on the list as a third tier surge capacity area. In our hospital, we have had to use expanded ICU areas and had to adapt other areas within the hospital for patient care, but we haven't needed to get even to the second tier surge areas. So it looks like, at least for now, that is not going to be coming for us. So now we would like to hear from you. If you'd like to share a comment, should simulation spaces be used as surge space for real patient care? Same instructions, favor, against, or conflicted?
And while people are putting those in, Christine, would you like to hear from the one person whose space is being used?
Absolutely.
Great. So Lisa Paganotti, you are on the air. Tell us.
Great, thank you so much. Yeah, this is Lisa Paganotti. I'm speaking on behalf of our lab out of Queens, New York. And so obviously, as you guys know, in New York, we have quite an issue with space. And so our simulation lab was actually occupying two old patient rooms, and it was on a floor with ambulatory care center. So when the surge began, they needed to take over that space for the additional patients. So the ambulatory care space was also taken over because all of those visits were moved to telehealth. And so what we essentially did was take literally everything out of the space. So there wasn't a single otoscope or ophthalmoscope left on the wall. It was just completely vacated, moved elsewhere, put into storage essentially at this point, because they just needed that space for patient care, which obviously is the priority. So that's our situation.
And that would take care of the figuring out which equipment was real and which was simulated. So interesting. Great, thank you.
Yeah, thanks.
Of course. So we have one person who's in favor. Denise Godinho, is that how you say your name? If I can unmute you. Uh-oh, I'm not able to unmute. Oh, there. Denise?
Oh,
Uh-oh. Denise?
can you hear me?
Yes.
I'm sorry, I'm having connection problems.
Okay. We can come back to you, okay?
Okay,
Thank you. Denise.
You sound good.
Actually, we can hear you.
Yeah.
okay.
Yeah.
So basically, our center, they've just done such an amazing job, much to what you guys were saying, that we have almost the exact same examples you were giving about monitors and about O2, but we have great like glass doors, places where we could really separate people. So I'm in the middle of laying out a whole document of all of the things that, because we're a college, we're not affiliated with the clinical site, there are things that, like all of our defibrillators are live, but they should probably go through bio first, things like that, and coming up with all of that information so that our administrators can distribute that, because all of these conversations are happening at such a higher level than the folks who actually are working with all this stuff day to day. So I find that the whole communication of what people's expectations are and what those big conversations are, and that they don't have all the information that they need to make really good decisions.
Makes sense. Thank you. And we have one person who was conflicted about it, Christine. Kimberly Bonton, you are on the air.
Oh, hi. Yeah, I sorry, I actually missed the first few minutes of the presentation on another call, but so it may have been touched on, but conflicted in wanting to help and support, but also in terms of, for us, our simulation center is within our college. We're not affiliated with the health authorities. we do have air units right now that can be turned over into oxygen, but we don't have all of the equipment that would be necessary. But I know we've been put forward as well as a potential should things should the need arise.
Great. Okay.
Yeah.
Thank you.
Also questions around, you know, who would be working within that area? Would our students be would our own students be able to work within that within our simulation center as a tertiary site? Just that's why I just have a lot of questions, so that's why I felt conflicted. Thank you.
I can relate to that. There's a lot of questions that come up with this. So thank you for chiming in. And Hannah Watts is against it. If I can get to, you're unmuted and you are on the air.
Hi, everybody. Good morning. I'm from Advocate. I'm the medical director for system simulation. I think I echo Dr. Park's sentiments about this, that we look at our sim centers and I have concerns about patient safety primarily. We want to help, but the gases are the main thing that really concern me, especially with COVID, that there's so much risk to our patients if someone gets inadvertently placed on one of our gases in our sim centers. We have considered our sim centers for like respite rooms for staff who need a rest. So again, we are opening up ideas to help, but I don't think patient care is a good idea.
Yeah, I would agree.
Yeah, great. All of that makes a lot of sense, and I would concur with the higher level people really having a poor understanding, and we experienced that as well. They said, "Oh, couldn't we use those rooms as ICUs?" So yeah, for sure. All right, let's move on.
That's great.
Topic number 3, Bob.
To be or not to be essential personnel, that is the question. And I have to say, and Christine and I have talked about that, I am conflicted on how do we determine who's essential? Like, is it people who are salaried versus our episodic, techs and SPs? I mean, how do we figure out, is it just people who have clinical assignments? I mean, how do we figure this out? And so I'm conflicted by this one. So I'm interested to hear what everyone has to say.
Yeah, and we have some interesting survey data to share with you. So some of you may have participated on an informal poll that we sent out to try and find out what people were doing. And I'm really pleased to share that survey results, those survey results with you now. So we had 242 respondents and with 3 questions. The first question was around what are the types of simulation that your center is doing today? Not surprisingly, about 2/3 of people are doing simulation, telesimulation or remote. About almost 30% are still doing in-center simulation, and about 23% are doing in situ simulation. And we will talk about this more. And then about a fair number actually said none of the above. And so we would be interested in hearing from that perspective as we move on. So next, we had respondents from all over the world. There was a heavy bias towards North America, but we did hear from multiple countries in the Middle East, Asia, Europe, Australia, New Zealand, and Latin and South America. And the results seemed to be fairly consistent across those geographic areas. We asked, is your simulation center in an area under stay-at-home orders? 90% of those centers of the 218 respondents 90% of the 242 respondents said yes, that they were. And now so this is fascinating to me. So we asked the question, how are your simulation staff currently designated? So there were a certain percentage where the staff are considered essential because the staff are already clinicians in the healthcare system. And so that made a lot of sense to us. But for those staff who are not clinical in the healthcare system, it was pretty evenly split between those who said that the staff are designated as essential and those who said the staff were designated as non-essential. And we really want to focus the rest of our time on conversation around this because it seems like we have some fairly strong differences in opinions and how people are choosing to use their simulation staff. Here were some of the comments in the comment boxes around the non-essential designation. So for some people, the faculty were able to go and do in situ sim, but the staff don't go to the clinical locations. In one sense, in one situation, the staff were switched to creating and making PPE for the clinicians. And again, third comment around supporting use of virtual and online activities. Now for the comment supporting the essential designation, in one case, the in situ simulation continued, but the changes were made around the numbers and observers to fit with physical distancing rules. And another, someone made the comment that anyone teaching is considered essential. And then on third, which is fascinating, is that all regular operations were suspended except for the in situ events supporting the COVID-19 efforts. So what we did at UIC is that we did make a decision to move all of our non-clinical staff to 100% virtual remote. None of our staff, except for me, because I'm already clinical faculty, come for in-center simulation or for in situ simulation. And I'd like to share with you some of our thinking around how we made that decision. So I relied on looking at the National Institute for Occupational Safety and Health, or NIOSH, the hierarchy of controls for hazardous exposure. And if we think about the hazardous exposure to our staff as being potentially COVID virus, the most effective solution is to physically remove the hazard. Next, if you can't physically separate the person from the hazard, then to replace the hazard. The next level down would be to try and isolate people from the hazard. So this would be providing things like physical distancing and other decisions. Administrative control, change the way people work. And the last and the worst, the least effective solution is to protect the worker with personal protective equipment. And the idea behind this hierarchy, as I said, is that the control methods at the top of the graphic are considered to be more effective and protective than those at the bottom. So in our math, we thought about, can we physically eliminate the hazard from our staff, which was to prevent them from going to in situ situations. We found that we could, and that we could provide the training in alternate manners. The other thing that we considered is the Healthcare Simulationist Code of Ethics. So even though for the most part we think about the Code of Ethics as focused on the learners, it really focuses on everybody involved in healthcare simulation, and that includes the staff. And so we relied on 3 areas within the Code of Ethics. One in the area of mutual respect, which is that we should strive to maximize safety and minimize physical and psychological risk. The next area was in the area of accountability, which was around designing and using simulations in a way that wisely uses available resources. Available resources include our human resources. And the last that we looked at was to maintain, also in the area of accountability, to maintain vigilance regarding not only the desired outcomes, in this case, providing just-in-time PPE training for healthcare personnel, but also potential unintended consequences of the simulation activity, which is potential exposure of our staff to risk. So taking all these things into consideration, we did make a decision to put a hard stop and a hard line around our staff coming in. And that is where we are still as of today. So now we would love to hear from you. We fully expect that there's going to be a range of ideas that we want to hear from as many of you as possible. So on the question, should non-clinical simulation staff be considered essential or non-essential as personnel? If you'd like to share a comment, type in the box essential if you favor essential, non-essential, or conflicted.
They're just now starting to come in. Sounds great. Okay, so interesting. So what classification do you want to go with first, Christine?
How about, well, well, you choose.
Oh my gosh, the choices, the choices. So there was no poll given, just people asked if there was a poll. There's no poll given. What we're asking is for you to take the slide on the screen and tell us in the chat box whether you think that simulation staff should be essential, non-essential, or you're conflicted, you're not sure.
And this isn't a poll, this is only if you want to speak to it.
Yeah, so this is only, so we have there's some people who've talked before. So I'm gonna say, there's several here. Oh, I love all these comments, sorry. I'm getting, Robin Wagner, though we heard from you before, she says that they should be essential. So let me get to Robin, you are on the air.
Okay, hi everybody again. Essential in a different, from a different perspective is what I'm thinking.
Okay.
Essential to, similar to what someone shared about educators, and anyone who's in education should be considered essential. All of us have been considered essential and have been required, even though remote, to continue being very active. I think essential is not always necessary to be defined by patient care. It's essential for us, especially in nursing education, is in Ohio. We're looking at getting those seniors out and rolling so that as we come up to a surge or reoccurrence or whatever is coming, that we have a continual flow of nursing personnel that's coming out into the work areas. So Ohio is even looking at allowing the new grads to work under a new grad licensure before they even pass their state testing, the NCLEX, so that they can get out there and work in the workforce. So I think that's the essential piece, at least from my perspective of educator, because you have to keep that pipeline to keep people out there and well educated. And then essentially, funny use of the word there, but essentially being able to help put the perspective of the living laboratory we're in right now for the students so they can absolutely see the critical thought process going on.
Okay.
Yeah, that makes a lot of sense, and it does partially depend on how you have defined it. So even though our staff are non-essential means that they don't have to come in for in-person work. So yeah, thank you so much for that comment.
That's a great clarification.
Yeah.
Great. Hada Khan, she said essential. You're on the air.
Yes, so I am from Canada, and our experience there that we have asked our staff to work from home virtually, and I think they are essential, yes, because at one time we will start going on again and we will need these people. So they are helping now of organizing all our stuff and all the things needed in case we are needed to help. So we are already categorizing our resources, what stuff we can give away, in which way we can help. So we are ahead of the game, trying to think out of the box. And at the same time, it's a time where we can organize all our paperwork and go through all our things. So I think they are essential right now to get ready in case we are needed, and on the long run when all this is over, in order to pursue again with our day-to-day work.
Okay, thank you. And then we have someone who's conflicted. Billy Paschal, You're on the air.
Great. Sorry, I had to pull back up I clicked the wrong tab. I'm conflicted. I am new to the hospital setting. I come from nursing education. I'm at a children's hospital, so we have not been affected as others in our area. It's just that sense of needing to help. I don't feel like I'm helping from home. I know I'm helping from home because I'm home, but it feels, I don't know. I can't explain it. It feels like it would, I would guess, wow, I just realized it's selfish. I want to be there so that I can show that I'm ready to help as I can. But I guess I'm conflicted because I know I should be home. There are definitely things to do. You know, that big list of simulation things that we always say, when we have time, we'll do this.
Right, no copious free time.
Yeah.
Yeah, I think also, Billy, you bring up a really good point is that, and with our staff, the discussion of them wanting to be there to help versus as leaders of a simulation center, am I willing to put the staff at risk, you know, and I think that's a decision as a leader that goes through my head. Joseph and Christine?
Yeah, I was going to add to that. It's very much our drive, isn't it, as humans, that we want to be able to help, and we want that proximity. It's difficult to feel like you're helping if you're, at a distance. So I think we've noticed that same phenomenon among clinicians. Some of them, interestingly enough, are reluctant to take the appropriate time needed to put on the PPE because of that same drive. I need to run in there and save this life right now. Yeah.
Yeah, interesting. One more conflicted, Robert McCauley, you're on the line.
Hello, I apologize. There's a lot of background noise. We're doing some renovations today. I'm conflicted. For me, ultimately, it comes down to having conversations with your team and eliciting from each member their personal comfort level. At UC San Diego, we are running some activities that are supporting the COVID-19 cause within our hospital system, and we do have to have staff come in, but we really sat down and just had a conversation to really find out where people felt. And I think you have to respect the individual's perspective on their own safety and how they best can, look after themselves. And so we did that, and I think we came up with a good compromise.
Good. Thank you. One more. Wait, you were here. Okay. So Dr. Baker from Rush has several thoughts about this. So I wanted to kind of hear from her. So Dr. Baker, you are on, if I can, there you go.
Thank you. Thank you very much. So I'm actually from Rosalind Franklin. My last name is Rush. It's always
I'm so sorry. That is correct. So sorry.
No problem. Ironically, I actually did my education at Rush, so it's just a little fun story.
That's what I meant.
Anyway, no worries. So I think one of the things that's important to highlight is the term essential, because while our simulation team is all remote at this point, we are working all off campus. However, we have been able to generate our simulations through different mediums, all remotely through telesim and otherwise, to maintain that training and that ongoing matriculation for our graduates. Many people have been talking about getting that workforce out there, and we are very committed to helping our healthcare students get out into the field, but not just to graduate. We want them prepared and safe and feeling as comfortable as they can going into uncharted waters. So it has been, I'm very proud and honored to work with the team that I have, because we are working nonstop to come up with creative ways, from our financial team to our SP educators to our faculty, and then reaching out across the university to gain creative insights on how we can generate hundreds of students through telesim and get them the quality that we are known to give, And so I just think it's really important to identify that essential. And I think somebody had said it earlier that it doesn't have to be a clinician or someone in the clinical realm to be considered essential, because without the people on our team from every training and every area, we couldn't do what we're doing. And so our team, every single member is essential. It takes a village. And so I just really think it's important. I think several people have mentioned that, and it's just really important. We couldn't do the volume we're doing without every member of our team.
Yeah, I think, that makes a lot of sense. And I feel like it is important for us to understand when we say essential from a value standpoint, of course, all our staff are essential. I would never say that they're not essential, but if we sort of for work purposes, classifying them as essential means that they are at risk of being asked to come in to do in-person work as essential workers. So that it's a great distinction for us to really keep in mind. And it's one for me to remember, because I don't want to say to my staff, oh, you guys are not essential.
Right.
I don't, from a value perspective, they are and do, and they're producing huge amounts of work, just like everyone else here in a telesim format.
Yeah. Great.
Great. So
looking at the time, yeah.
Yeah, we have the time. So I wanted to share with you a little bit about what we did for just-in-time PPE training recently. So, and it's because the stay-at-home order came down right as we were starting this. So the goals were very simple: just don and doff PPE, and the others to experience some of the physical and communication challenges during an emergency patient care scenario. So we did this over 4 days, about 100 anesthesiology personnel. We started on one day. We did small groups of no more than 6 learners with 2 techs, so that we were under the 10. And we did that in center on day 1. The stay-at-home order was given at the end of that day, which was a Friday, to begin the following day. And so the remainder of the training that we did was done in a conference room by me and one of my CRNA colleagues. Here is what we found that was really, really interesting. You can see that the environmental fidelity and physical fidelity is super low. That is an intubation head with a box for the patient's body. But the process fidelity was very high. And by that, I mean that everyone had to don and doff the PPE exactly right. They had to pay attention to how their body moved. For example, you can't turn your back on each other or reach across each other. And we found that people responded with very strong emotions, even to me verbally saying the O2 sat is now 63, even without the beeps. So what we found is that adhering to the process fidelity, and also given the heightened emotional commitment that people had to learning, is that the exact physical fidelity was not important at all. And so we felt that there was no quality lost by doing it this way under these circumstances, compared to doing it in center or even in a real in situ clinical environment. So that was something really interesting that we learned that we didn't really know about ahead of time. So great. Now let's go to the polls for the final poll.
Final poll. So we've had this great discussion, but we kind of just want to see where everybody's at. So what is your general reaction to classifying simulation center operational staff, not clinicians or faculty, as essential personnel for in situ simulation during the pandemic? Again, essential being that they would not be affected by stay-at-home orders, shelter in place. They would actually be asked to come in to perform simulations. So what is your general reaction to classifying simulation center operational staff, i.e. not clinicians or faculty, as essential personnel for in situ simulation during the pandemic? So I'm in favor, I'm against it, or I'm conflicted. So we'll give you just about 2 more seconds, and I'm gonna end this poll.
Wait, guys. Oh, okay. Never mind.
And check out the results. Here are the results.
All right. So of about half of you who got to vote, we have about 50% who said against, 16% in favor and about 30% still conflicted. So yeah, that does make a lot of sense. I think in our conversations, we do feel a little bit of that pull back and forth ourselves. Okay, great. We want to thank you guys so much for joining us for this discussion. We know the time went pretty fast. We weren't able to get to everybody for comments, but I am really happy that I feel like I learned a lot and sort of got a sense of what people are thinking. We want to share with you a couple of upcoming events. One, next Wednesday and Thursday, so it's April 22nd and 23rd at the same time, 11 a.m. Central Daylight Time. We're going to have a two-part webinar on how to turn mannequin-based scenarios into 100% virtual, live, and interactive telesim. So this means everybody participating from home, including techs, embedded participants, and everyone. We want to let you know that we have over 900 registrants already for this, and our cap is 1,000. So if you're interested, please go ahead and register. And then the other is next week on Friday at the University of Minnesota. They are going to be providing a really interesting webinar at 11 a.m. on Friday about providing direct support for frontlines providers. Things like doing central line training, using GlowGerm for experiments to show the spread of virus, and other interesting topics. So we really encourage you to join in for that webinar. I know that I will be tuning in myself.
Yes.
Great. And finally, we want to conclude by thanking you so much again for your time. We know that time is valuable. This is a picture of our almost our full staff. And then my contact information and also Bob's contact information. We hope that you stay safe and have a great weekend. Thanks, everybody.
Thank you.
Bye.
Bye.